Orthopedics, ankle pain, investigating. Keep investigating until you find the cause of the ankle pain. Use CT for osteochondral injury, MRI for soft tissues. And how to fix it. Often an arthroscopy is useful with 2.7mm scope and chondrotomes. Remove synovitis. Also, you may need to do a lateral ligament reconstruction for instability where it gives way with positive anterior draw sign on examination. Case 1, fracture lateral process, 36-year-old male worker. No pain after 3 months. Leave it. You can also see it demonstrated on the CT. Here's another case, case 2. Injury to the ankle 30 years ago, now painful and stiff. 60-year-old man, secondary OA, cyst formation. May need to do an arthroscopy, be difficulty of access, maybe curette that cystic lesion. Case 3, retrocalcaneal bursitis, painful, swollen around TA insertion, difficult to deal with, large bony exostosis in the region. May need to remove that fragment. Case 4, tear of the tendo Achilles, positive Simmons or Thompson's test. He was able to get up on toes but weakness. The MRI showed it. He had a delayed repair. Case 5, a comminuted fracture of the calcaneus, 40-year-old active man. 3D reconstruction showing it. You can classify it, but basically you need to know the widening of the calcaneus, the loss of Boyler's angle, and the extent of the involvement of the subtalar joint. Grossly swollen ankle, left for a couple of days for the swelling to settle down. Do a lateral incision. Reduce the posterior lateral incision. Once you reduce the subtalar fragment, a hole is left. You have to fill that hole with bone graft. I use synthetic bone graft such as Hydroset. So you elevate the subtalar fragments, fill the resulting hole, fix it with a synthetic bone graft, and then hold it with a plate. Wound at 7 days doing well, little red. Post-op x-rays showing reconstruction of Boyler's angle, narrowing of the heel. Wound healing slow over 2 to 3 months, finally healed at 5 months. Here's another case of retrocalcaneal bursitis, exuberant exostosis, excision, remove that bony fragment. Case 7, painful foot, looked like a Charcot joint here 3 years ago, now has OA of the navicular cuneiform articulation. So look at this gross loss of bone density, joint destruction. Looks like a Charcot foot several years ago. Maybe it healed. Now she's got resulting OA. Case 8 of a Weber C fracture of the ankle, markedly displaced. Look at the talus way out to the side. Closed reduction, internal fixation, plate lateral malleolar, syndesmotic screw fixation, medial malleolar fragment. It was slow to heal by 2 to 3 months, so I did a small incision over the area and used Vitos synthetic bone graft into the region. Here it is. It works like putty, easy to place. Case 9, a very severe divergent ankle fracture, Weber C. Closed reduction, fixed lateral incision, long reconstructed plate firm, syndesmotic screw placed. Here's a post-op x-ray, syndesmotic screw, long plate, restoration of the mortise. Keep a close eye on this. May need actually bone grafting at the 2-month stage. Case 10, pain and clicking by the peroneal tendons, post-reconstructional lateral ligaments. Here I am going endoscopic examination of the peroneal tendons. Small incision just behind lateral malleolus. Put a scope in and look up along the tendons to see if they are intact. Because the MRI here said there's a small tear, but the endoscopy did not show this. Demonstrating it, set up with the endoscope. Very easy to get a good view, and also use chondrotome to tidy up. Hope you find these cases useful. With the ankle pain, investigate carefully. CT, MRI, don't hesitate to do arthroscopies, as it can allow you to get the basis of the problem, including looking into the joint and looking along the tendons, such as the peroneal tendons, endoscopic synovectomy of peroneal tendons.